Now, as much as everybody thinks this is important, it's not without controversy. Because some people say that you shouldn't completely use mortality as a quality indicator, because a lot of time, a lot of patients come to the hospital, but they come here to die. We can't save them no matter what we try. So if you have a lot of sick patients dying in your hospital, that might not be a bad thing. That might be that you actually did a good job of taking care of them and making sure that they were comfortable before they died. So a lot of people say just measuring the mortality alone is not a fair way to grade hospitals. What you should be trying to do is grade or figure out what is preventable, figure out what preventable mortality is. But of course, there's no measure for that. So that's the struggle here, okay? But because so many deaths still occur in hospitals today, and we know that things might be unpreventable today, but they may be preventable tomorrow, people believe that we still need to keep going down this road. And the best example I can give with regard to this is, 15 years ago, everybody used to say that central line infections, they weren't preventable because it's just a risk of getting the treatment. But of course, today we recognize that if you're actually very careful and have a good process, they're almost completely preventable. So people say that we might get better with mortality in this regard, and that's why we need to keep going down this road. Does that all make sense so far? I'm almost done with the background, then I'll get to what we're trying to do, okay? There are many ways to measure mortality. Some people say just look at the number of people that get admitted and the number of people that die, and that's the rate that the hospital gets. So my hospital, we have about 55,000 people admitted every year. About 1,000 people die in our hospital every year. So it's a rate of about 1.8% for us. So 1.8% of our patients at my hospital die. Now, you could take that 1.8% and compare it to other hospitals, but the problem is if you just do it with the raw rate, people don't like that because we argue that our patients are sicker. And it's not fair to compare us to a hospital where the healthy patients go, because they might have a much lower rate. So some people say, okay, that's fine. Then what we should do is we should do something that we call risk adjusting. You take all the factors in for all the patients that come in, and you come up with a risk-adjusted rate and compare that way. And of course, the other way people measure mortality rates is they say, well, it's not just good enough that you measure people if they die in the hospital. You should also follow them for 30 days afterwards to make sure they're not dying within 30 days of the hospitalization, because otherwise the hospital could do a bad job, discharge the patient. If the patient dies right away, you're missing the fact that the hospital didn't do a good job. So these are the different measures out there for measuring mortality. None of them are perfect, so most people actually follow all of them when they try to figure out what's the best, how is the hospital doing. Now, risk adjustment is something that carries a lot of interest for people, but the challenge with, and these are the factors that we often risk adjust for, because we have to bill for all of our patients. They can get all of this information from the billing data that we bill for, okay? And these are kind of things that they use to put in the risk adjustment calculations. Now, it turns out when they try to risk adjust to figure out how many of your patients should or should not die, when they put these factors in, there's still a lot of controversy, and I'll show you why. We don't need to go into a lot of detail here. Yes?
Could you come back?
Yes.
Which one is this one? The name of the model?
These are just, this isn't just one model. I listed all the factors that the different models use. Okay. Now the problem is this. Depending on the model you use, you can get different answers. So what you see here is that this is a UHC model. You can't read this, but that's okay. This is 3M. This is Thomson Reuters and Dr. Foster. And these are the same, if you look here, this is the percent of hospitals. You can't read this, but if, I'm not going to do a good job. Basically, at the end of the day, depending on what model you use, you see that you get different answers on how the hospitals perform. So the model determines what kind of answer you get. So nobody knows what the right risk model is. So this is why hospitals still complain about risk adjustment. Okay. And here's an example of how we're doing. You can see our hospital's more, this is unadjusted mortality. I don't know why this number's a little off. I need to double check. But here's our hospital's mortality over time, and here's our case mix index. So this is the risk adjustment factor that you can say, this is how complicated our patients are. And you can see that our patients are getting more complicated and more sick with time. And here's our mortality rate, which has stayed in this range. Okay. So that's just an example of how, yeah, you can see in the US, the mortality rate has remained stable for the last few years, around 2.1% and 2%. Okay? But the case mix index is actually getting worse. Okay? So that's the numbers. But the real question is with the hospital, you can put these numbers in front of people. So people often put this in front of me and they say, well, Alan, your hospital's mortality rate is 1.8%.